Let me introduce our next speaker, Dr. Suman Ghosh, who's a pediatric neurologist at Maimonides Medical Center and associate professor of neurology at SUNY Downstate College of Medicine. He specializes in neonatal pediatric neurocritical care, cerebral palsy, spasticity, and brain injury medicine. His research interests are in neural development outcomes and brain injury biomarkers for neonatal and pediatric brain injury. Dr. Ghosh consults on patients with brain injury from the initial hospitalization in the ICU. He continues to work with patients and parents for rehabilitation specialists to optimize patients' recovery and neurodevelopmental outcomes. Dr. Ghosh is board certified by the American Board of Neurology and Psychiatry in child neurology and epilepsy. And he's board certified by the American Board of Pediatrics in pediatrics as well. He's an active member of National Committee for Child Neurology Society and Neurocritical Care Society. He's also an active member of the research committee at SUNY Downstate and Maimonides. Please join us and welcome Dr. Ghosh for pediatric stroke management.
Thank you for that lovely introduction. So we're going to switch gears. Hey, where's my slides? There we go. So we're going to switch gears a little bit to a different population. I assume the majority of this audience is adult neurology. Is that correct? I do see a handful of folks that are pediatric. Okay. So my talk is on both neonatal and pediatric stroke. The basic question is, can you actually do T and K in kids? So the basis of this talk, we're going to go over the incidence of stroke in pediatrics. Now, the good thing is I get to sleep better than you guys because the incidence of stroke is a little less than what you have to deal with. And my population that I deal with is usually not lifestyle induced. So there's that. There's different etiologies, however. Compared to adults, my patients typically don't, well, now as they're teenagers, but in general, they're not smoking. They're not usually type 2 diabetics that are hypertensive and having like 3 meals of barbecue every week and with dyslipidemia. So it's a different patient population, which also makes it quite challenging when it comes to the various etiologies that are associated with it. Now, there's obviously challenges in the diagnosis for pediatric stroke. And I'm not just talking about the fact that you're dealing with a 1-month-old or a 2-year-old who probably doesn't really say anything beyond 2-word sentences, is probably not going to be oriented to person, place, and time. He's just oriented to the fact that he's in a hospital and there's mom around him. So there's obvious issues with that. Also, in older children who have other risk factors, such as if you have cerebral palsy or you have autism or other systemic disease. But there's also other challenges to the diagnosis, mostly in the form of delay in diagnosis and a delay to imaging. And treatment, it's a different beast. Yes, it's stroke, it's vascular territory, but the etiologies are different. It's not all thrombus or embolus here. And so this treatment for this is based on the different etiologies. So I figure we just jump right in. Oh, I have no disclosures related to this topic. So let's just jump into a pediatric stroke. So you're called in. Now, sometimes some of my adult colleagues get called for a pediatric stroke and they're rushing in, and the patient that they see, they're called to the NICU, not the neuro ICU, but the neonatal ICU. You're like, what am I doing here? How do we even examine this thing? And you're called to a child who's day life 2 going into 3, male, who's having a right focal tonic seizure, just involving the arm for about an hour. Mom was home with the child, doesn't really know last known well, because basically babies eat, poop, sleep. So in between somewhere along those lines, sometime the mom woke up and found the child in the bassinet having the seizure, rushed him over to the hospital. While in the emergency room, he gets Ativan, he gets phenobarbital, and the seizure stops. But it's noted that he has decreased movement on his right side, both arm and leg. The child is born to a 25-year-old G1P1 mom, a 41-week gestation. This was supposed to be a home birth. However, because of prolonged rupture of membranes, about 20 hours, and mom developing a maternal fever, the doula decided to convert this to a midwife delivery in the hospital. Pretty uneventful. vaginal delivery, 7 pounds, APGARs are 9 to 9, no resuscitation needed. The child had some markers drawn, a CBC, a culture, CRP. Child looked fine. There was no obvious source of maternal fever other than presumed chorioamnionitis. And so the child went home. And then this happened. So there's a family history of stroke. It's in the paternal grandfather who lives in Tennessee. He owns a barbecue joint, so you can kind of figure that one out. As far as the exam, it's a little difficult. Patient's intubated, patient's ventilated, but is still alert. Is someone interacting with you, but you've noticed that there's a decrease in movement on the right arm, right leg, and deep tendon reflexes are increased on the right. There's a positive Babinski, but it's bilateral because it's a neonate. That's normal. So the obvious questions are like, last known well? I don't know. A NIH stroke scale in a neonate. Hold on, let's do this. Okay, level of consciousness. All right, somewhat somnolent, maybe. Orientation. Yeah, good luck with that. Response to command. Gaze, visual fields. How about you tell the patient, lift your arms up for 5 seconds, 10 seconds. This is not happening. So you have to use other things. And what do you do for a diagnostic workup? Do you send this kid to a scanner, get a head CT? Do you rush him over to get an MRI, MRA, MRV? Do you just watch the kid? Maybe get an EEG and see if the kid's still seizing. These are all questions that pop up. So we'll go to our first audience response question. What's the next step in management of this case? Well, what do you want to do? CT head, CT angiogram, CT venogram. We're doing MRI brain, MRA head and neck with an MR venogram. We want to just do continuous EEG monitoring because, I mean, it is pediatric neurology, half our patients sees. You want to just do a head ultrasound. It's one of the few times that you can actually do that. This is an open fontanelle. This is just skin and brain. Or do you want to do a hypercoagulable workup here? Actually, I have no way of knowing who's responding to what because I don't have a pop-up here. So, just going to click through. Probably not a CT in this scenario. CTs have other ramifications and increased risk of other cancers. We'll go into that a little further. MR brain, this is a patient who is intubated on a ventilator. You can imagine the airway is a little difficult considering the airway is not here to here, it's this. So you move about a centimeter, you've lost your airway. So probably not that right now. Head ultrasound? Head ultrasound is great for looking at blood, but parenchyma in the neonate, which is mostly protein and water, probably not likely. And hypercoagulable workup. I was taught a long time ago that this is what we do for all our pediatric stroke patients. We get protein C, protein S, methyl tetrahydrofolate reductase deficiency, factor V Leiden, Russell Viper venom, lupus, all these other fun labs. Turns out, not really helpful. So continuous EEG. Main reason why in this scenario is this, as mentioned before, 50% of our population for pediatric neurology seizes. The #1 presentation for a child like this is going to be seizure as a presentation for stroke. It's not going to be hemiplegia. So coming back, maybe this is not a stroke. I mean, common things being common, more likely this is going to be either sepsis in the NICU or meningitis, hypoxic ischemic encephalopathy, although your history doesn't say that. Cerebral hemorrhage, it used to be a common thing, but the fact that this is a term baby, this is not a premature infant, less likely unless there's an AVM or something. Cortical malformation or genetic or metabolic predisposition to seizure, potentially. And this is just a Todd's paralysis most likely. Or I guess this could be a neonatal stroke. Now, sorry, but this is not pediatric stroke, this is neonatal stroke. Stroke differential is different in a neonate versus a pediatric patient. And for those in the audience, a neonate is up to 28 days corrected gestational age. So this includes your 23-week premature infants all the way up to 28 days corrected. So the first question I always get asked, also by many other folks, not just adult neurologists, but pediatricians as well, is can babies actually have strokes? And how common is this in pediatrics? So there's been multiple studies that have shown in based on countries, the United States, Canada, Australia, and Europe, and the UK, where they've looked at the different incidences of pediatric stroke. This most recently is a systematic review combining all the literature records that are out there along with major hospital databases and major countrywide databases throughout Europe, the UK, and the United States. And although there's some differences as far as, there we go, there's some differences as far as the patients and the incidence in the UK versus the United States and Europe. In general, the majority of pediatric stroke, as far as the incidence, occurs in this neonatal period, so 0 to 28, up to about 29 days. This is the majority. Overall incidence is about 4.65 per 100,000, but as a neonate, this is anywhere from 25 to 30, depending on the literature. And it drops down steadily, so about like 1 year of age, where it comes down to this like 2 to 3 per 100,000. There's a slight increase towards the later teen era, mainly because of things that a teenager does, like drive, wrestle, get into fights, get carotid dissections. My favorite is stealing one of these little electric scooters and going down Bay Parkway without a helmet. Also, now we notice that there's more adult risk factors in some of these teenagers, like dyslipidemia or poorly controlled type 2 diabetes. So that's why the little bump. So for now, we're just going to focus briefly on this population. So neonatal stroke, very similar to adult, 80% ischemic. The majority is going to be ischemic pathology, with 20% being hemorrhagic or cerebral venous sinus thrombosis. Now, there's several different types of neonatal stroke syndromes. Perinatal and neonatal the terms are used interchangeably. Oftentimes, they're going to present in the acute symptomatic. So your arterial ischemic stroke tends to be your most common. Cerebral venous sinus thrombosis is like 1 in 100,000. So this is fairly rare. It's probably even less than that. Hemorrhagic stroke used to be something very common, either not just from AVMs, but also premature infants who may have a parenchymal bleed that goes into the ventricular system. But due to advances in neonatal care and OBGYN care, this has actually decreased significantly. Now, on the flip side, sometimes these patients don't present acute symptomatic. And when we mean acute symptomatic, usually in the NICU, they're presenting a seizure, usually focal seizures. After that, you may see some signs of hemiplegia, facial asymmetry. They're not going to have any balance. Perinatal stroke syndromes are found later. These are patients that present later on, say around like 4 months, 6 months, 9 months. They may not initially present with stroke-like symptoms. They're presenting for developmental delay, hemiplegia. They're presenting for signs of cerebral palsy. They're just not able to move their right side as much as their left. And when you image them, they're found to have a stroke. Whether this happened in utero or this happened around the time of birth is hard to tell. But usually, most of these tend to be in more of a utero phenomenon, both arterial and venous. Now, why does this occur? In neonates and also in pediatrics, a lot of this has to do with inflammation, whether it's the mom or the neonate. Now, things that occur, the basic idea of this is there's some underlying systemic inflammation, there's elevations in TNF-alpha and IL-1 beta. This results in a cascade of things through either vasospasm or focal thrombosis, eventually just leading to an arterial occlusion of some pathology. And in some cases, the clot itself may not necessarily be just thrombus. It may be a collection of thrombus plus immune cells as well. In rare cases, we do see clots cross over from the placenta and embolize to the child, but this is fairly rare. So coming back to the different factors or etiology for neonatal stroke, again, it has to do with inflammation, either from the mom side. So thrombotic states, pregnancy in itself is thrombotic. So we're talking about other things like inherited thrombophilias, which turns out is actually fairly rare to the point where we stopped checking for it unless there's a strong family history of it. Mainly also because a lot of the factors that we draw from the neonate are going to be the mother's factors, or 30% of those factors are going to be low anyway in a neonate. They don't really come to normal values until about 8 or 9 months. So what do you do with that data? So oftentimes, if there's inherited risk, we'll do some labs, but we're going to repeat those later on in life. Autoimmune disorders and drug abuse can cause some vaso-occlusive disease, resulting in a neonatal stroke. Preeclampsia, you're looking at about 5 to 10% of the population of pregnant mothers who have preeclampsia. This is a large population. Also, things like infection, both from the mom and also for the neonate themselves. Other things to consider: congenital heart disease, which is a major contributor for neonatal stroke. With advances in CT surgery and pediatric cardiac ICU care, these children are surviving. However, because of the increased survival, because of surgical technique, unfortunately, this also increases your risk of stroke. These chambers have very turbulent flow. They tend to have other factors that increase their risk of clot and stroke. Other things, catheter-related issues, and other miscellaneous factors. Gender: in pediatric stroke, males tend to get more strokes than females. Race and ethnicity may have to do with also the fact that there's higher incidence of preeclampsia sometimes in certain ethnicities. In general, however, if you take those factors out, Black and Asian backgrounds tend to have a higher history of stroke. And dehydration is another one for venous sinus thrombosis, mainly because it's a mom who's trying to feed a child, breast milk doesn't fully come in, and they don't realize the child is being dehydrated until it's already too late. So diagnostics, the main thing we do is clinical exam. Continuous EEG takes precedence, mainly because in a lot of these patients, and in neonatal stroke and seizures in general, 10 to 16% of these patients will have subclinical seizures, even on top of their regular seizures. So after you stopped it, they may still be seizing. Also, phenobarbital in neonates causes an electroclinical dissociation, meaning you stop the clinical seizure, but electrographically they're still seizing. One stable, an MRI, MRV. As far as the thrombophilia workup, again, it's based on history. And then echo and Doppler, I tend to get a lot of these because I'm biased. I used to see a large congenital heart population. But once you have lines, not just umbilical and arterial lines, there's a higher risk of clot. Treatment. There's no TNK or TPA here. There's really no thrombectomy, with the exception of certain populations. Congenital heart patients, especially larger congenital heart patients, post-op, you can consider doing intra-arterial TPA or thrombectomy, but those are rare and in very, very specialized congenital heart centers. The main thing is really seizure control, and the good thing is most of these children do not go on to become epileptic. They have seizures, and it stops. You're able to actually take them off of medication prior to discharge. The main goals are things like maintain cerebral blood flow, perfusion pressure, make sure they're euglycemic, normonatremic, and hyperpyrexia and dehydration should be avoided. Now, people have looked at, well, is there a role for antiplatelet or anticoagulation for certain populations? In general, when people looked at the incidence or recurrence of stroke in this population, it turns out anticoagulation and antiplatelet don't really have much of a difference. Yes, there's a slightly less stroke in the anticoagulation population, but there's a higher risk of bleed. And antiplatelets, unless there's a strong indication, so a thrombophilia or a congenital heart disease patient, typically in general, most of these patients don't need it, mainly because the recurrence risk is low. Now, people have also looked at using hypothermia. Therapeutic hypothermia is used for hypoxic ischemic encephalopathy, so a mom who delivers a child with low APGARs, has acidosis, has a lack of generalized cerebral blood flow. And in some centers which use therapeutic hypothermia for HIE, or hypoxic ischemic encephalopathy, they've also looked at applying this for neonatal stroke. Unfortunately, it turns out the data doesn't really support any, doesn't provide any extra benefits for this. The outcomes are still about the same. And also, people have looked at erythropoietin, not just for HIE, but also for neonatal stroke. These are small studies, about an N of like 9 or 10 for erythropoietin, and showed no immediate benefit for stroke. And then recently for HIE, or hypoxic ischemic encephalopathy, there's no benefit at all for that. The good thing is, mortality is fairly low, and the recurrence rate is very low, mainly because the offending agent, or the cause of this, is pregnancy. It's mom. You take the child out of mom, recurrence rate is gone. You take the offending agent out. So unless they have other diseases like thrombophilia or congenital heart disease, recurrence risk is fairly low. Outcomes, however, this is a disease that has a higher morbidity associated with it, particularly cerebral palsy. A third of these patients will have spastic hemiplegic cerebral palsy followed by diplegic or ataxic. However, function is actually pretty good. So this graphic is the gross motor function classification system. It's a functional classification system of how disabled you are as a child with cerebral palsy. Most of these children are level 1 or level 2. So they're able to go up and down stairs, they're able to walk independently. They may be a little slower, but they're still able to traverse different terrain, from asphalt to grass to sand. So it's not major concern. Rarely do we see children become a level 4 or level 5 where they're requiring significant support or full assist. So the outcome is good in these patients. Intellectual disability does occur in these children. About a third of them will have some underlying intellectual disability. I didn't put in here, but behavioral problems can also occur. About a third of them tend to have behavioral problems, may develop learning disabilities, ADHD, and other learning disabilities as time goes on. As far as epilepsy, not all of them develop epilepsy. Only about 15 to 22%, and the majority of them are going to be on monotherapy. So we're going to switch gears now. We'll do another pediatric stroke, but we'll do an older patient this time. So you're called to the ED for a 3-year-old male who has a history of viral gastroenteritis. And basically the child was like early Head Start or pre-K or something like that, a little precocious for his age. But he comes off the bus and he essentially wobbles and falls off the bus. He has a right arm and right leg weakness with a facial droop. When asked when did this start, the child and the teacher says, well, you know, Johnny was just like, toward the end of the day, he just kept falling and he looked like he was tripping. We just thought he was a little tired, so we just put him in a chair. So this is probably around like 2 o'clock. You pick him up around 3 o'clock and find this. So the mom brings her into the child into the hospital. Past medical history of asthma, there's some family history of epilepsy, and on exam, there's a right facial droop, right arm and leg weakness. There seems to be impaired sensation. You do pinpricked on this child on the right side and doesn't really seem to respond as well. And it's hard to also say if the child actually isn't really responding because, well, there's speech involved. And has a Babinski that's positive on the right. So this is not the child I'm talking about, but similar. So as far as what's the etiology and how do you work this up? And you're within window here. Do we do TPA? Do we do TNK? What do we do here? So coming back to this lovely graphic about the incidence, now we're talking about this population. So we're talking about 29 days and above, particularly in at least 1 or older. Now, the incidence of pediatric stroke globally is about 2 per 100,000. However, the highest risk is in the first year of life. And unlike our neonates, it's about 50-50 hemorrhagic versus ischemic. Now, I'll dive into a little deeper into the ischemic side of things. The majority of this, about 45%, are going to be focal cerebral arteriopathy. About 30% of these patients will have some of patients with ischemic stroke may have a cardioembolic event. Majority is going to be congenital heart, but it can be acquired heart disease, or it could be just from procedure or catheterization. Some of these patients will have dissection, about 7.5% to upwards about 10 to 12 will have dissection. And the other 17.5 are going to be things like thrombophilia underlying inflammatory disease, some genetic or syndromic features. Now, as far as focal cerebral arteriopathy, the trial on vascular contribution of infection in pediatric stroke of the VIPS trial, trials 1, 2, and 3, found that throughout the decades, that majority of these children are going to be a post-infectious process. It's not an active infectious process that's invading the intima and causing this focal stenosis. And it's usually not just one area, it's multiple areas of stenosis, with one exception. Varicella does have direct invasion. These tend to be focal and they're non-progressive. Now, there is a recurrence rate, but usually that has to do with the fact that if it's not a post-infectious process and more of a systemic vasculitic process, then those are the patients that will have recurrence of this. Now, I do need to mention sickle cell arteriopathy, which does have a 100-fold increase of stroke compared to the general population, and it's mostly ischemic compared to hemorrhagic. The majority of these children are going to have clinically silent strokes in the deep white matter. Clinically silent is a bit of a misnomer in the fact that our exam is biased towards motor function and things like cognition. We usually don't pick up on an NIH stroke scale or when we're examining these patients. But if you ask the history, parents will tell you, so-and-so had, great academics or was fairly decent. And within about like a few weeks to a month, all of a sudden the child's a D student, has trouble paying attention in school, has difficulty focusing, just seems very out of it. And that's usually the sign. Now, the good thing is sickle cell arteriopathy and sickle cell stroke has gone down significantly thanks to chronic exchange transfusion and the use of hydroxyurea. Now, cervical dissections, about 7.5 to 20% of pediatric arterial stroke. The majority are going to be anterior intracranial, and oftentimes it's not a recurrent disease unless this is a non-traumatic. So you're talking about children who have an underlying collagen vascular disease or other connective tissue disorder that predisposes them toward dissection. Congenital heart disease, this is a personal favorite of mine, 30% of pediatric stroke. And again, this is with increased survival of congenital heart. Now you have more patients who have strokes. As far as the interventions that we do from a congenital heart standpoint, certain interventions carry a higher risk of stroke, such as the Berlin Heart or the X-Core, followed by ECMO and Fontan, even cardiac catheterization for initial evaluation. That carries a 1 to 2% risk of developing stroke from just that. People have done transcranial Doppler studies listening to what happens during a cardiac cath. It's hard to tell if it's really emboli or not, or what is it? Is it really clot? But you do hear a fair amount of high-intensity signals on TCD when you do a cardiac catheterization. Now, there's a 19-fold risk of stroke in congenital heart disease, but the risk does not go away when you're corrected or when you're an adult. In fact, when you're an adult, children with congenital heart disease who become adults have a 10-fold risk on top of all the other risk factors that they gain as an adult. Now, there's also some genetics involved with pediatric stroke as well. Depends on the patient population, like RNF213, which is associated with Moya-Moya syndrome, or POLG1 or MELAS, which are mitochondrial diseases. Now, I mentioned half of this is going to be hemorrhagic. The majority of these patients are going to be vascular malformation, so AVMs, cavernous hemangiomas. Unfortunately, a third of them are undetermined, meaning we can't just figure it out because it's a hemorrhage. The field is already covered in blood. It's oftentimes that's the only vascular abnormality they may have had, or it may have been an ischemic stroke that converted. Now, as I mentioned before, most of what I see as a pediatric neurologist is going to be really seizures. Stroke, it's fairly low incidence. So more often than not, you're going to have stroke mimics. The majority of them are going to be seizures or Todd's paralysis. We do see our fair share of hemiplegic migraines that often get called as a stroke code at least 2 or 3 times before finally someone makes the diagnosis. Other things like transverse myelitis, demyelinating disease, and unfortunately, we have our fair share of psychogenic events as well. So a lot of these patients, most of them tend to be a mimic. So our next audience response question, what's the most common cause of pediatric stroke? Is it cardioembolic, post-infectious arteriopathy, ruptured AVM, sickle cell arteriopathy, or an inherited thrombophilia. So let's start knocking some of these down while y'all are responding. Correct answer is B, post-infectious arteriopathy, which is not a clot-based disease. This is a stenotic disease. Good. So some of the challenges for diagnosis, some of it just has to do with recognition. Oftentimes, the frontline people are going to be emergency medicine or general pediatrician. Unless stroke is in their differential, they're not going to identify it. So it's often that's part of the delay. Examinations are difficult, as mentioned, but imaging also can be a delay. Now, this is an older study back in 2009. This data comes from the Hospital for Sick Children up in Toronto, the home of Gabrielle de Weber, who is essentially known as the godmother of pediatric stroke. In this center, there are several stroke experts. They instituted a stroke code. This is one of the earlier pediatric stroke codes in the, not in the nation, in the world. And in this cohort, what they found, the median delay to diagnosis was 22.7 hours. And it's not the parent's fault here. I mean, sometimes it is. Parents may not seek medical attention, but the majority, I mean, when you look at the pre-hospital, 1.7 hours to get to the hospital. This is Toronto. The delay is in-hospital delay, 12.7 hours. Now, 20% of these patients get diagnosed within 6 hours, but the main issue is this delay in initial time to imaging, 8.8 hours. Some of that just has to do with some of the logistics associated with it. For a pediatric patient to hold still, even if they're having a stroke and they're hemiplegic on side, they're still fairly active. So oftentimes you'll need pediatric anesthesia. Trying to get pediatric anesthesia on board, trying to get them coordinated, trying to get an MRI, trying to move another patient off the scanner to get this patient on because you're suspecting a stroke. And first thing that I usually get is, really? A stroke in a child? Are you kidding me? And so, yeah, I can see where there's a delay in this. And in some cases, the NIH stroke scale that's applied, or the PEDS NIH stroke scale, the score is fairly low. And there's usually not an alteration in consciousness. So oftentimes this is delayed. Now, what's happened since 2009? Some improvement. So some studies have shown, so this is by Harar in 2020. This is at Boston Children's. So Boston Children's, will give you a little bit of context. 60 pediatric neurologists. You have a pediatric stroke team. You have a neonatal stroke team. You have a pediatric neuro ICU. You have 24/7 coverage of child neurologists in-house to evaluate these patients. And also, you have a well-oiled machine that has pediatric anesthesia on 24/7 and MRI capability 24/7, multiple scanners. Even at that institution, this is up in Boston, 2.75 hours from initial symptoms to hospitalization. So people in Boston just take a little more time getting to that hospital. But once they're there, in-hospital delay is fairly minimal. It's about 7 minutes. Time to imaging, about 1.4. So majority of patients, from time arrival to diagnosis, about 4.3 hours. So much better than was about a little more than a decade ago. Now, does this apply elsewhere? I mean, Boston Children's is an exceptional hospital, but it's not the norm across the country or across the world. A similar, well, I would say not similar to Boston Children's, but a well-staffed hospital in Ankara, Turkey, this is a Turkish study, with a pediatric stroke team, a pediatric stroke code in place. What they found is their initial symptoms to hospital delay is 4 hours. So that's the biggest delay. But time to imaging, no, these are well within an hour. So their diagnosis time is much quicker. So instituting a pediatric stroke protocol, yes, it reduces the initial time to initial imaging. It reduces the hospital delay, especially for a child who has a low NIH stroke scale. It's a faster time to intervention and faster antithrombotic initiation if you need antithrombotic initiation. Now, as mentioned before, in the Boston study, majority of these patients had MRI, MRA, MRV, 85%. Even in their population, they had 50% who had a head CT. It's not because the MRI scanner was down. It's because anesthesia just had a hard time anesthetizing these kids enough to hold still for these images. Or there are other contraindications, like the kid was actively seizing, or it was a difficult airway. So majority of these patients got, well, not majority, but 50% got head CTs, and then within 6 to 12 hours got an MRI sequence. Now, in the Turkish study, what they found, the sensitivity of head CT for detecting a stroke is about 42%. The majority of pediatric stroke will be head CT negative for the first 6 to 12 hours. And oftentimes it's so small, you may not necessarily really appreciate something on CT. You're going to need an MRI. Now, if you just did a T2, T1 MRI, 50%. You need diffusion in these patients. And an MRI angiogram does increase that sensitivity a fair amount. However, most centers are going to have that. Most centers are not going to have 24-hour MRI capability or 24-hour pediatric anesthesia every day of the week. Now, head CTs are not benign. A recent study, so we've known for a while that CT radiation exposure increases your risk of leukemia as a child. Now, the European EPI-CT study, this is 276 hospitals. Initially, the total amount was almost about 900,000 patients. Final data points have boiled down to about 658,000. And what they found was 165 patients with brain tumors. About 75% of them are gliomas. If you do the math, that's about 25 brain tumors per 100,000. That's the same incidence of neonatal stroke. That's higher than pediatric stroke. And unfortunately, the higher the milligray, there we go, higher the milligray, the higher relative risk that occurs. Now, put things in context. For here, head CT under 1 year of age is below 40 milligray. So we're around right here. It's about 2. Once you hit above 1 year of age, it's below 80. So higher relative risk. On top of that, if you had an angio, head and neck, not talking about a CT perfusion, I'm just talking about the head and neck angio. That's 98 milligray on top of this. So you're already way out here. So for a disease that has a low incidence rate, do we really want to CT these children? Now, depending on the clinical indication, if you're concerned for hemorrhage, probably yes. But if the concern is less, maybe we need to do something else. As far as treatment, I hate to break it to you, but there's not great data out there for use of TPA in pediatrics. The data comes from expert opinion. One of the best studies, sad to say, was a retrospective study back in 2017 of 12 children. 12. One of them got a thrombectomy. And what they showed was that the median door to needle is about 240 minutes. This is probably making my adult colleagues cringe right now. No intracranial hemorrhages in this population, and the modified Rankin score, this is a pediatric Rankin, is fairly low. So yes, it can be used. The risk of hemorrhage, which early on some of my colleagues are very concerned about, it's fairly low risk of hemorrhage. And in general, it's fairly low disability. Now, I do have to say that in pediatric stroke, half the children with pediatric stroke have a good recovery. Disability is not very common, or they may have some disability that with rehab, with a lot of therapy, can improve. Now, the TIPS trial was an interesting trial trying to do TPA in pediatric stroke across the country. This is a major trial. This is going to make headlines. This is back in 2012. So I think, yeah, I was still in residency. And so 22 sites, 17 active sites. It took a little while for everybody to get their act together, figure out how to mix TPA, have a dedicated hood, make sure it's on the protocol, how to do it with pharmacies and things like that. And out of all these sites and all the money that was spent, 1 patient was enrolled. It was a patient in Dallas, Texas, out of 93 screened. Needless to say, the NIH didn't pursue this any further. But from those 93 patients, it just basically confirms the majority of these patients are stroke mimic. 54% are going to be benign mimics. Of the other non-benign, things like hemorrhagic strokes, infection, methotrexate, or PRESS, of the 46 that are confirmed had medical contraindications or time to presentation greater than 12 hours. So you lost your window. Had a low pediatric NIH stroke scale, or diagnosed between 4.5 to 12, or were outside a window, no clot visualized. And then this is the one child from Dallas who's enrolled. So a fair amount of mimics. Now, people have talked about, well, why don't we use TNK? We kind of have to, because our adult colleagues are using it. TPA is gone out the door at this point, and so now it's TNK. Most recently, there was a survey done of different stroke centers in pediatrics, and we're talking about 11 unique cases that have used TNK. So not great data, of which 7 are male, 10 of them are between 13 to 17, so older patients, and they presented with classic findings of hemiplegia or slurred speech or balance issues or visual field deficits, and one of them between 5 or 12. And in this study, what they found was, yes, there's no hemorrhages. It works just as well. These patients survived. And majority of these patients, got their their TNK within a reasonable window. One was greater than 6 hours, and that child did also well. The dosing, same as adults, 0.25 mg per kg. Mechanical thrombectomy. Here we have a little better data. So this is a study using a California database, mostly Kaiser, of 3,184 cases of pediatric arterial stroke, of which 1%, 38 of them, got endovascular therapy, 19 of which had TPA. This is a later study than the previous one, the data set. They were older patients, classic stroke symptoms or findings, and unfortunately about 45% of them had a poor outcome. Most of this was thought to be related to the underlying systemic disease or the other disease process that contributed to this stroke. But no one had an intracranial hemorrhage. So in general, based on expert opinion and the comfort of your interventional neuroradiologist, yes, it is recommended that if it's possible, you're going to go after it with thrombectomy, or you can use other treatments. So which one of these is actually FDA approved? Is it TNK? Is it aspirin? TPA? Thrombectomy? Or none of the above? Now this is fairly easy. Nothing I do in pediatrics is FDA approved. I take it back, some things. Now, I mentioned before, 45% of pediatric ischemic stroke is going to be focal cerebral arteriopathy. There is no clot. So people have talked about using steroids. Now, back in the 70s and 80s, steroids were fairly in vogue, where pediatric neurologists were using steroids for treatment of this, thinking that, hey, this is going to be an arteriopathy. This is probably in a post-infectious process. Looking at the imaging, has a very classic beating pattern to other types of diseases. Let's hit it with steroids. What's the harm? It's just inflammation. And those patients did improve. Steroids all of a sudden fell out of favor, mainly because, hey, we have TPA now in adults. Why don't we use it in kids? Now, most recently, steroids have come back into popular demand, similar to what we do in the 70s and 80s as far as fashion. Now it's fashionable again. We call it mid-century modern. So the steroid use in this study, this was a study looking at the use of steroids along with an antiplatelet regimen to see if there's any improvement in long-term outcomes. And in this study, what they found was, yes, there's a statistically significant improvement in the children who received corticosteroids plus platelets in their cognition, in their behavior, in their speech, not their motor findings. But they also noted that use of steroids has steadily increased due to this paper and plus other papers as well. Most recently, now there's a trial called the FOCUS trial. Essentially, it's the use of, for focal cerebral arteriopathy using corticosteroids, where essentially if you have a patient who you suspect a focal cerebral arteriopathy, they come in within 24 hours of stroke onset, and you have imaging confirmation on MRI, then you can give steroids. If you choose not to, after 24 hours, you repeat the imaging, and if there's progression of disease, you can choose to give steroids. That is currently ongoing. Enrollment, as illustrated by the TIPS trial, I would say it's better than the TIPS trial enrollment. So far, I think they're up to 22 patients across the country, and there's multiple sites. In order to be a site, you have to have the capability of doing MRI for your stroke patients in a reasonable fashion. Outcomes, as mentioned before, unlike our neonates, neonatal outcomes, a lot of that improves with neuroplasticity. It's a neonate. You can retrain the brain to map out to different areas. In an older child, almost half of these patients will have moderate to severe disability. Half of them are going to have hemiparesis, and about a third of them will require special education as well. Now, only 10% of them develop epilepsy, and fairly easy to control epilepsy. So in summary, I want to go over with you all the difference of, compared to adults, neonatal and pediatric stroke, that there is a diverse set of etiologies and risk factors when to this disease. It's not the same as adults, and it's not all clot-based. There's a lot of challenges still to overcome in the diagnosis, and treatment may not be the same as adults. So, thank you.
Any questions for Dr. Ghosh in the audience and online? Yes. Dr. Zumafan first.
Hi, Daniel Sumofen, one of the endovascular guys. Amazing talk, super good, loved it. A thrombectomy and pediatric population. I did understand most of the strokes are stroke mimics. I did understand don't touch the neonates. I did understand that most strokes in the non-neonates are in fact vasculitis. And I did understand in the few cases where you can attempt a thrombectomy, the results are not great. Can you define in which patient pediatric you would foresee a role for mechanical thrombectomy?
So, excellent question. This is not an easy question to answer. It really depends on the patient and the etiology. So, if you do have a clot that's a proximal vessel clot that you can basically throw in a catheter and retrieve, the patient's within at least 12 hours. You can argue that up to 24 hours, depending on the severity and depending on the patient. So in general, my experience has been like your patients with sickle cell that are posterior fossa, basilar, it's hard. Those patients have vasospasms. They do not do well with that. So that's a population that we typically not treat. Now, if it's an LVO, yes, those patients do benefit. So large vessels are easy to go after, but you really do have to have good confirmation that there is a clot, it's proximal, it's something that you can go after safely. There's no other contraindications such as a disease that would end up in more vasospasm. And you have to have the appropriate imaging and collaboration with colleagues. So it's not just a one-person decision, it's a group effort to decide. So there are patients, I will say they're exceedingly rare. I've had more thrombectomy patients than I had TPA patients, per se. But usually it's specific populations. The majority of them are going to be congenital heart or something that you know is going to have a major clot.
Hi, very nice talk. Thank you for the information. Is there any relationship with autism? You mentioned epilepsy as one of the outcomes. Is there any relationship that you've seen with autism?
Not directly with autism per se, as far as like a causation for that. It just is difficult with children with autism to diagnose stroke because it's often difficult to examine them in some cases unless you have a way with them. So it's just a challenge, but there's no direct link with autism in pediatric stroke. Now, for neonatal stroke, there is some, I don't know if it's statistically significant or not, of neonates who've had pediatric stroke, or sorry, neonatal stroke or other brain injury. There is a higher risk of autism in that population. Now, whether it's due to the underlying fact that they had a stroke or were they predisposed genetically to have a stroke and underlying genetics regarding their autism, that I can't answer.
Excellent talk, Suman. Thank you very much. When we're adult neurologists, we're always taught that kids are just not little adults. And the pharmacokinetics and pharmacodynamics of medication may differ. So I'm curious, did we just latch on to an adult dosing of TPA and TNK for these trials? Or why aren't we doing the same feasibility studies of dose escalation. I know the trials to date risk, but in terms of knowing that a lot of them have good outcome, we really want to improve on that outcome with the safety profile of maintaining minimum risk. A better dosing concept and reality than just assuming it should be the adult thrombolytic dosing?
Excellent question. One of the and it turns out at least in the TPA literature, the type of clot that a pediatric patient will have is far different as far as the lacing of the thrombus, about how the clot is, the integrity of the clot. You often will need higher TPA dosing for this. So unfortunately, we did latch on to the adult dosing when we know full well that children will tolerate higher dosing. This is not just in stroke, but also in cardiology as well, where you can use higher dosing of TPA in these patients. The problem with feasibility and dose escalation is you have a disease that's fairly rare, and you have to come in within window for TPA or for TNK. And we have trouble just getting them in the door, let alone the scanner, let alone trying to get them in for just TNK.
Thank you.
You're welcome.
So there are a couple of questions online. One is about gestation and inflammation, saying that the gestation is a low inflammatory state. How do you reconcile that as a risk factor, during pregnancy?
I mean, typically that we look at pregnancy as higher clot state, particularly in that third trimester or closer to delivery. Some of that has to do with other risk factors associated with pregnancy, mainly things like infection, but also blood pressure as well. But in general, there's a higher amount of cytokine, chemokine profile in pregnancy especially as you're delivering and toward those latter weeks. And so that's why, in general, we consider this a higher inflammatory state.
So the question about lactogenesis and with the supply and demand between mother and the baby. So
usually it's not just as simple as like the supply and demand process when it comes to lactogenesis for a mother and newborn. There's other risk factors, but oftentimes it's just lack of supply or poor technique. Not necessarily that the milk hasn't really come in. Now, this is a population. Now, unfortunately, we do see many first-time moms and even just seasoned moms. Breastfeeding is not as easy as it used to be. It's not something that you do out in public anymore, like back in the day or other countries. And oftentimes you don't have the same support. So I'm not necessarily to say that it's more of a supply demand. In some cases, there's just not enough supply, or it just takes more time, or they're just not getting enough, or they have underlying illness. So for instance, if it's a neonate who has a diarrheal illness and has more losses that just can't be accommodated by breastfeeding, and those are other patients that are at risk.
I have two quick questions, if I may. So do you have a cutoff for CT scan, the age, in terms of, we know neonate, we don't typically do them, it's not easy and whatever, between pediatric and older kids, do you have a cutoff? One, do you use CT as opposed to MR-based imaging triage?
So it really comes back to age and etiology. If you're it's easy to say that if a teenager comes in, yeah, they're probably more adult physiology, let's get a head CT and such. Also, the dose risk from a radiation standpoint leading to brain tumor, or even from the leukemia literature, the dose risk is higher in the earlier ages. But there's not like a hard set cutoff. I'd be sort of guessing to say that you would just do adolescents get a head CT and you don't do that in younger children. I wouldn't necessarily do that. It depends on the situation. Ideal scenario would be a fast protocol MRI where you just need diffusion, ADC, an SWI, and a T2 flare, and then just call it a day. Typically, in other centers I've been to, that sequence can take 3 to 5 minutes max. That you can give a child a little bit of intranasal Versed for oxylytic dosing, throw some Benadryl on there, something just keep them calm, get it done, and avoid the radiation exposure. Plus, avoid having to use anesthesia. So that would be the ideal situation. But unfortunately, I don't have a hard and fast for you as far as when to do CT.
So more of an individualized based on the patients and age and all the other factors together.
Correct.
Okay.
But ideally, in a lot of other centers that use MRI instead, they're using FAST protocol initially. And then if it's someone who they suspect is a thrombectomy candidate, you're within window, those are patients that you're calling in the anesthesiologist, doing full sedation, getting the scan properly done.
Now, for patients who have severe strokes that have, say, hemispheric dysfunction and hemispheric injuries, based on I think the numbers are correct, is 50% of them can have, that doesn't mean that the other 50% of people who had injury actually adapt and actually had decent clinical outcomes?
I would say decent. It's not that they're completely, it doesn't completely not like alter their life. Their lives are permanently altered. Even when children and young children in particular, there's still subtle signs that you see with rehab, and at least with pediatric and neonatal brain, we actually can really live the term of neuroplasticity. Nothing's hardwired yet. It's a term that's used in adult rehab for stroke, but our population can't actually do it well. So oftentimes, it really depends on the child, it depends on the rehab resources, and if it's a large hemispheric stroke, we do have patients that, yes, they're hemiplegic, but not to the same degree. You can have the other motor strip take over in some cases. It depends on how early you are. So it's one of those that, I mean, I hate to say it to parents, but it's like if you had to have a stroke, you want it very young, as a baby or like as a toddler, versus if you're a teenager and had a stroke, where the outcome is going to be different.
Gotcha. Excellent talk. Thank you.